Now I call upon Dr. Sujata Guha ma'am to talk about preventing and managing visual access opacification after cataract surgery in children.
Good morning, everybody. At the outset, I would like to thank ARC and AIOC for this opportunity. Now, visual access opacification is one of the most common and important complication of pediatric cataract surgeries. And if you leave the posterior capsule intact, the opacification rate is 100%. If you remove the posterior capsule and retain the anterior vitreous or the anterior hyaloid, the opacification reduces by 60%. And if you remove both the posterior capsule and the anterior vitreous, the visual axis opacification reduces by 6% to 6%. So with this background, let me focus on a few ways of preventing visual axis opacification. One of them will be very copious hydrodissection and intraoperative polishing. If you are leaving the posterior capsule behind, these two will reduce the burden of lens epithelial cells and will leave lesser epithelial cells to migrate and cause visual axis opacification. The next key thing that you can do to prevent posterior capsular opacification will be doing a posterior capsulotomy. Here the sizing of the capsulotomy is important. 3.5 to 5 millimeter would be a safe size to prevent a membrane from forming. And you can use cutter or a rhexis forceps to do it. Again, as I stressed, anterior vitreous vitrectomy can also reduce the visual axis opacification. And last but not the least, an optic capture, which is nothing but pushing the IOL optic behind the posterior capsule to reduce, again, to cause fusion between the anterior and posterior capsular lip and reduce the migration of the lens epithelial cells into the anterior hyaloid. Now, the lens design and material is also important. So if you are leaving the posterior capsule intact, a hydrophobic lens with square edge can reduce the posterior capsular opacification. And post-operatively, copious steroids with a good cycloplegic agent can reduce inflammation and thus cause reduced PCO. Now, the preferred practice for doing a posterior capsulotomy is that till 6 years of age, you will do a posterior capsulotomy with an anterior vitrectomy. From 6 to 8 years, do a posterior capsulotomy. You need not do an anterior vitrectomy. And in children more than 8 years, we usually leave the posterior capsule intact. However, this is not, the age is not a watertight thing. You should treat the patient and not the age. So in patients with developmental delay, in patients with traumatic thick fibrous capsule, patients with nystagmus and patients who will not be able to sit and keep their face in a YAG laser machine or will be unable to come for follow-up, you can consider removing the posterior capsule and doing an anterior vitrectomy even in older children. Now, once you have a visual axis opacification or a posterior capsular opacification, how can you treat it? ND-YAG laser, of course, is the first choice. But in children, lasers have a recurrence rate of almost 30%. So these children will come every summer vacation for a posterior capsulotomy. And usually the lens epithelial cells proliferates along the anterior hyaloid and thus causes visual axis opacification. And if usually these opacifications are thick and they might not be cut with ND-YAG. So in that case, you need to do surgical membranectomy. In aphakic children, we usually prefer membranectomy through the limbal approach. In pseudo-aphakic children, we can use either the limbus or the pars plana. Now, in certain special situations like persistent fetal vasculature or anterior PHPV, when the capsule is very thick, we will cut the capsule definitely and fashion a posterior capsulotomy around 3.5 to 4 millimeters and then slip in the intraocular lens. In inadvertent PC rents in children while polishing, we can actually convert the rent into a CCC, that is a continuous rhexis, and then do vitrectomy and place the lens in the bag. In high myopes is an exception. We actually don't touch the anterior hyaloid because risks of retinal detachment are rather high. So if it is a very small child with a high axial length, we prefer doing a posterior capsulotomy and not disturbing the anterior hyaloid. And if they're at a very high risk with other eye having retinal detachment, we sometimes leave the posterior capsule intact even though the child is very small. In patients with coexisting posterior lenticonus where the posterior capsule is already open, we can fashion the posterior capsulotomy with the cutter with adequate sizing and then slip the lens into the bag. And in post-vitrectomized eye with silicone oil, usually the posterior capsule again is fibrotic and thick, so we need to remove the posterior capsule even if the age is older. So to summarize, if you are leaving the posterior capsule behind, doing a good hydrodissection, polishing your posterior capsule will reduce the chances of posterior capsular opacification. In children below 8 years, you should remove the posterior capsule. You may or may not do anterior vitrectomy in slightly older children. But beyond 8 years, you prefer to keep the posterior capsule and the anterior hyaloid intact, thinking that you can do a posterior YAG laser capsulotomy except in special situations that I mentioned. Thank you.
Thank you, ma'am, for your wonderful videos and tips.